So our next speaker, Kristen Verderame. Just a couple of comments in introduction of Kristen. She joined the AAHC, that's the American Association of Academic Health Centers, in September of 2014, so just about a year ago, as a Director of Government Relations. She spearheads the association's efforts in front of Congress and executive branch agencies, promoting the voices and views of its members with the highest level of policymakers in Washington. She previously spent over 20 years working in government relations and public affairs. It's also noteworthy that she holds several advisory roles outside of her day-to-day professional responsibilities. Of note, she's been actively involved in the network of British American organizations in the US and the UK for many years, currently serving as Vice President and General Counsel of the British American Business Council. Finally, Ms. Verderame received her JD from the University of Michigan Law School. So we've had two Michigan graduates as the first two speakers here. She also completed post-JD coursework at Georgetown University Law Center. So she's going to be speaking today to talk about the results of the AAHC roundtables on GME reform. Please join me in welcoming Kristen Verderame.
Thank you. Thanks, I'm happy to be here and I'm happy to represent yet another Michigan grad. This is great. I'm not big on pro football, but I'll talk college football all day long with you. So if you want to talk after this, I'm happy to do it. Happy to be here today. I'm not sure if all of you are familiar with the AAHC. If you're not, we are a relatively small organization, about 20 people, representing academic health centers. So we work a lot with the CEOs of your organizations on a number of different things. In government affairs, we are very strategic in what we do because we are a small organization. We have elephants like the AAMC and other really big groups out there handling every issue known to man. So we are very strategic in what we choose to work on, really pulling on the uniqueness of who we represent. So we work on issues that are really interdisciplinary in scope, for example, and issues that uniquely address the academic health center communities. So one of the big issues we are working on is GME. I started a year ago, and Dr. Wortman, our CEO, said, why don't you start out with an easy topic? How about GME? And I'm new to healthcare. My background is not healthcare at all, which I think has actually helped me in this process. I've been able to very objectively look at this process and say, what were they thinking? What? This is how it works? So as you may know, when the IOM report came out, Dr. Wortman and the AAHC wrote a letter congratulating them on a really good report, on their ambitious undertaking of doing the report. We do not take a position on GME reform and will not do so. We are a neutral organization on the topic, but we acknowledge that it's a very important area, as we've certainly learned over the last several months as well. And we're here to help. We're here to facilitate. We're here to provide information on the topic. Okay, so when I went to Congress to say, okay, we're going to do this issue called GME, what could we do to help you? Given who we are and on our position uniquely, interdisciplinary, representing the management of these big organizations, uniquely AHCs, what can we do to help? And the answer I got was, we hear the same arguments all day long. The same bills come up, oh, we want more slots, we want to redistribute the money, it's all about the funding. Can you come and tell us something that we don't know? What don't we know that's actually happening in this community? So we said, okay, we'll go find out. So we actually went on a listening tour, and I'll show you where we went. We had 7 roundtables across the country. Now, I know that Dan was at our roundtable in Salt Lake, and Michael Finley is here, who was at our Stanford session. Is anyone else here that participated in our sessions? Ah, yes. Which one did you participate in? Oh, in Utah as well. Excellent. Okay, great. So you guys can correct me if I say something that's wrong or add flavor to it, which would be terrific. So we had 7 sessions. We tried to cover the whole country on a regional basis. We went to the regions themselves on purpose. What we tried to do is engage as many folks as we could in the process, capture as many states as we could, regions. We also included a number of different organizations. We don't need to be the only one talking at this table. We want all stakeholders at this table to make it as effective as possible. So we invited all the different associations that are working on the issues, as you can see here. AAMC joined us in Atlanta, AHA was in Chicago with us, AMA was in Chicago with us. So a lot of them joined us. We invited insurance companies. Kaiser was with us. I know we have a Kaiser gentleman here today. We had Kaiser with us in Stanford. And in each session, we asked the local host to suggest who were some of the local experts that would be great to have at the table. So we ended up with some really unique folks joining us. The Georgia Board for Physician Workforce, for example, Utah Medical Education Council, the folks in that region who really have expertise in these areas that do not sit within AHCs. We invited folks who were not our members. You know, whoever really had a good voice at that table, we wanted them to be there. We were very opening about that on purpose. And as you can see, we covered most of the states. The gentleman who was there from the University of Washington, and I know we have a lot of Washington folks here today, represented most of the WWAMI states, or the whole contingent, if you will. So it's actually a little bit larger than that. It was really important to us to figure out what the regional differences were. What is unique to each region, if anything? So we were very specific and controlled about how we conducted these seminar sessions. We had the same opening remarks, and Dr. Wortman teased me about having to read from a script every time, but I made him do it on purpose. We had the same materials, same format every time. And we asked 2 questions, only 2. We said, we do not want to hear about funding. That's all everyone hears about. More slots, more slots. We don't want to talk about that. We don't want to talk about geographic redistribution. That's all everybody talks about. We don't want to talk about that. We don't want to talk about whether there's a physician shortage, another topic everyone talks about. All these rabbit hole issues, there's been enough debate and discussion about it. We don't want to hear about those. So to fulfill Energy and Commerce's question, what else is going on out there? So we said, what are the top 2 issues of your institution, your state, your region? What's unique to you in GME? And you can raise funding, that's okay. You can talk about slots, that's fine. That's not the focus of our conversation, but what were the top 2 issues for you? And secondly, does the current program support training physicians for the future, looking ahead? Does it really fit as you're moving ahead in technology, in consolidation in the industry, and all the things we're facing going forward? And what we got were the most amazing sessions. They were 3 hours each. I sat through every one of them, took notes through all of them. All of them were completely unique. It was fascinating, actually. Consistent thread through all of them, as I'm sure these gentlemen here will attest. Everyone there very willingly took off their day hat and talked genuinely about the issues. There were folks that really spoke against their own institution's interests, their own personal interests. They really opened up in the discussion. And across the board, it wasn't what I thought I might hear, people fighting about money. It was, how do we get healthcare to the people? It was very inspiring for me as new to the healthcare world. I wasn't quite sure what I'd hear. And it really was. Everyone who came to these sessions, and I say that without exception, the concern was, how do we get healthcare to the population? How do we help our patients? Full stop. That was what everybody was concerned about, which is great. So there are 8 areas that we distilled all of these conversations down into as themes that we think represent what is happening in GME across this country. There were many, many sub-themes. I have more data on this than you can imagine. So if anyone wants to talk into detail about any of these, I could provide hours and hours of detail for you. But there are about 8 areas that we kind of wrapped everything up into, and I'm going to walk through these briefly with you today. And then I'll talk a little bit about, answer any questions that you might have about any of these specific areas, talk about next steps, what we hope to be doing, and recent conversations I've had on Capitol Hill about where maybe this can be going. Okay, kind of to supplement what Gail talked about earlier. So the first one, and we put this first on purpose because this is a fundamental issue, is organizational conflict. In every single roundtable we heard, there is a different mission between the person getting the money and the person having to do the education. Just like Gail said, right? Money all goes here, everyone else has to implement it over here, and nobody sees what's being spent, there's no connection. We heard about hospital systems saying, oh, hey, we're gonna open a new cancer wing over here because we wanna get all these new patients in and make all this more money. And the medical school saying, what? Wait, oh, hold on. We need to now staff that. Right? There's no continuity, which to me is a little bit crazy, coming in from the outside. So funding and also missions not aligning, huge, huge issue. This fueled so many of the different issues you're going to see. It's amazing. And fascinating to me, this occurred even when the same institution owned both the hospital and the medical school. Like, how is that possible? So what we did is we ended up pulling out some of the best practices of where it wasn't such an issue. And kudos to those in Salt Lake, in the Mountain West region. And remember, I don't know if you remember, I asked this question. I said, is this an issue for you guys? They said, no, we all get along great. So interestingly enough, in the Mountain West region, I don't know what water they're drinking, but they don't have any issues on this for whatever reason. They work really well between their institutions. But every other region, this was a huge issue, even where, as I said, there was ownership across the piece. One of the best practices we unearthed was really cross-board membership. If you take someone, the dean of your medical school, for example, and put them on the board of the hospital, or vice versa, that helps a lot. Shared board ownership was a big issue that we talked about that could be a useful best practice going forward. This was a really interesting one for me because I do a lot of work with startups and innovation in the rest of my day job. There is a lot happening outside of academic health centers, a lot in terms of healthcare, in terms of disruption, consolidation of the industry, new technologies. And in these discussions, it became very clear that a lot of it's happening that the AHCs are completely unaware of. They just don't know what's happening around them. We heard in Dallas how there's a command center in Dallas that monitors the healthcare of 5,000 patients in Las Vegas. It's a command center, and whenever they need anything, they dial into their UberDoc service, and a doctor is sent out to them from the local area, and their needs are met. Fascinating. There was another gentleman with us in Dallas who talked about coming from a private sector organization, and he said that when he got a medical student, a resident graduated out of one of the AHCs to come into his organization, he had to spend an entire year training them before he could actually use them. An entire year. And I've heard that again and again. I can't even tell you how many times. We were in Stanford, and Michael might attest to this. I said, here we are in Stanford. We're right next to the most innovative area of the whole country. You guys must be working with startups, and oh, this is great. You have access to all this technology, innovation. And they're like, not really. We don't really do much with them. I'm like, what? So there's a lot happening in the area that academic health centers are just not involved with. Now, there was a recognition that if we don't get involved with it, it's going to pass us by. Those UberDocs, the consolidation of the industry, the CVS Minute Clinics that I love as a mother with young children, it's very efficient for me. There's a lot of innovation happening that if you guys don't get involved with it, it's going to pass you by, and that's not a good thing. So one of the things we're going to try to do is educate all of our membership about what is happening so that you are made aware of that and can help participate and benefit from all the innovation that's happening around us. Mental health and wellness. I think we all know that mental health is one of the biggest issues our country faces. You all know more than I do in more specific terms. But we learned how mental health within the residency programs is at an epidemic level. So students are falling over more than they ever have. Suicides. I don't think we've read a roundtable where someone didn't mention a suicide that they had recently experienced within their resident program. Faculty mental health issues, driven by a number of different things, driven by the crazy schedules, driven by student debt loads, driven by high cost of living in the areas like Stanford, Palo Alto, where they're trying to go to school, driven by faculty being told to teach more and more and more without getting more and more resources. A whole number of things feed into this, but the bottom line is the mental health of our residents and faculty is really, really bad and needs to be addressed. So in addition to the population at large, which we heard about as well, population is having significant mental health issues, and there's a bit of a shortage in addressing that. Definitely the case in the academic health center GME environment. This was an interesting one. You can imagine that in our conversations, the ACGME was raised a lot. And they actually joined us in Chicago, which was very helpful. Paul Rocky, you guys might know, a lot of you might know Paul. We talked about how in medical school, it's a one-size-fits-all. No matter what you're going to be, what kind of physician you're going to be, you get the exact same education. You have to go a certain number of years, can't go any shorter, you have to take these certain classes. And we learned again and again how it's really inefficient and unproductive and really not very effective, frankly. You don't have time to teach technology, innovation. Doctors going forward may not need to memorize every symptom of every disease ever because they're going to have a device in front of them where they can look stuff up. What they need to know is how to analyze that data, how to apply the data. You know, this is a whole new world we're moving into. And you don't have time to teach it because you're teaching all the same things that you've taught forever. So is there flexibility in the accreditation requirements? ACGME says there's actually a lot of flexibility, that it's more of an institutional issue, that you all are so dug into what you've been doing that you just do the same thing over and over. I'm guessing the answer's somewhere in the middle. That's an area that we're going to try and explore with another roundtable, frankly. But if we were to fix this and tailor the programs in a more customized way, in a more flexible way, we think we actually could address some of the mental health needs and some of the other issues that we've seen throughout this process. We heard from NIH in DC talking about how their research physicians have to do an emergency room rotation. Well, why? They're going to be sitting in the lab the rest of their lives, so they're like, why do we have to do this? And they have to pay UVA to go use their facilities, truck the students across to do this. It just doesn't make any sense. We heard example after example of how that one-size-fits-all just isn't working. So is there some sort of flexibility there? Can we do things differently? And the recognition across all the roundtables was, hey, we're the ones sitting in these ACGME committees. We can actually change this. Why aren't we doing this? So I think there's, I don't want to say low-hanging fruit. Actually, Gail and I had breakfast. We were talking about whether this really is low-hanging fruit or not, how hard this would be to make some of these changes. So there's a debate about that, how easy it might be. But there's definitely a willingness to fix it, and you all are the ones that can fix it. ACGME took our presentation that you're seeing here and presented it to their board. Paul did. And they're aware of our findings. He was participating in the Chicago session, as I said. So we plan on working with them going forward and trying to get to the bottom of this a little bit more. There's also an interest in coordinating the curriculum in a larger span. So right now there's UME that does its own thing completely, GME does its own thing, and then CME does its own thing. There's no continuity whatsoever. And we talked about, well, that doesn't really make a lot of sense. If someone knows they want to go into a certain area, can't they start a little earlier, cut down some of the debt that they might have to accrue, all the different things, minimize it? And CME, we're moving into a world where just because you say you want to be a certain kind of doctor when you're 22, does that mean when you're 35 and the population needs something different, you can't change? You can't move into that direction. Right now, no, you can't. There's no flexibility to address changing population needs. So is there a way to coordinate the curriculum in a broader way that might help that? It's a very fascinating area. This was an area, and Gail touched on this a little bit in her SDOH discussion. The needs of the rural and underserved is another area that impacted across every region that we went to. I grouped these together because it's not just whether you have a physician to provide you care in a rural area, it's whether you have the right physician to provide you care in that area. We heard in Stanford about how 1 in 5 babies born are of Hispanic origin. And yet 2% of the GME residents have anything to do with the Hispanic culture, language, background, anything. There's a real mismatch there. So this is meant to capture all of that. You know, how do we serve the needs of our resident or our rural patients? How do we serve the underserved people in the way that's the most effective for them? I can tell you that the roundtable in Salt Lake was fascinating because we talked not just about rural, but frontier. And I think rural is defined 200 miles from an academic health center. So imagine what frontier is. I think there was one health center in all of New Mexico. I'm staggering how they have to supply physician care to these people. So this is across the country, even in Philadelphia. I didn't think we'd hear much about this, but there are rural areas in Pennsylvania, rural areas in New York, rural areas everywhere where patients are really needing care. So as you can imagine, telemedicine came up in this, how to provide it across state lines, across broad areas. Project ECHO is a great project we heard about in New Mexico, where they have a physician expert in New Mexico at the academic health center, and they have someone in the community who's been chosen to be kind of the person expert in that area, and they don't even have to be a physician necessarily. Once a month they have a conference call, talk about the patients, talk about diagnoses, different things, and coordinate on that. Problem is no one can bill for that time because there's no patient there. So Project ECHO is great. It's done really well. It's been very successful. I actually heard a hearing on the Hill last week where it was raised as a really good example of telehealth. So it's getting a lot of attention, but there are some issues with funding and other things that need to be solved. And partnerships are critical here. Can't do it by ourselves, which leads us to partnerships and interprofessional care. I grouped these two together because everyone acknowledged across the board that this is the future. We're going to have partnerships to provide the level of care we're going to need to provide. We're also going to have to work in interprofessional teams and team-based medical care to provide the care patients are going to need going forward. And the challenges are very similar. Challenges with different missions, that's a biggie. Challenges with geography. All of that affects both those areas. So we have identified some best practices, some academic health centers that do this better than others, and we're going to be sharing some of those over the next several weeks, so stay tuned for that. I think that, frankly, academic health centers are in the best position to address the interprofessional training issue because we represent all the disciplines. I can tell you that on my government affairs team in the NAAHC, I have a woman who is the lobbyist for the American Association of Colleges of Nursing. And we're going to be pulling other disciplines into our work for that reason, because it really should be a broad spectrum of the disciplines, not just medical schools. Workforce, certainly Gail touched on this earlier. This is an area that is really the elephant in the room. Everyone knows that it would be really helpful to have some sort of workforce estimate so we know what to plan for. The debate we really had was not whether there needs to be some sort of analysis, but how do you do that analysis? So everyone thought, great idea to fund the National Commission. I don't know that it'll ever happen, but it would be great. But everyone thought, yeah, that would be a helpful thing to do. But really, in these conversations, it came down to, that's probably not the right level. Sometimes it's statewide, and a lot of states are doing a lot of good works in this area, and I can give you some best practices from different states that we observed. Sometimes it's at the local level, and sometimes sublocal. At Stanford, again, we talked about Orange County, how there are a lot of really affluent people there, and everyone assumes everyone there is really affluent. But actually, no, there's a huge portion of it that's the underserved community. So you really can't even do it by county sometimes. It has to be sublocal. And in Atlanta, we talked about how the region that would be appropriate for it is actually where all the 3 or 4 states come together. So you can't just say, oh, you need a national, you need a state, you need a whatever. It really does depend on the community itself. And the other question is, how do you measure it, right? What metrics do you use for that? I was told that the EHR systems are EMR, EHR, all these acronyms, the health records that you guys keep. Sometimes you can track for that, and some are building in codes so that you can track what people are up to and what they're doing. I understand that once you graduate, you say, okay, I'm going to be a pediatrician. But 5 years from now, you may not be a pediatrician, you might be doing something else, but nobody's tracking that. So when do you track it? And what do you track? That's the hard part. Now, obviously, funding is a huge issue. As Gail spent most of her time talking about funding, and everyone in Capitol Hill, that's all they talk about is funding, funding, funding. Clearly, we learned that if the funding was adjusted, not even fixed, if it was fixed, it'd be great. If it was adjusted, the incentives will change, of course, and a lot of the things that we found may be solved or helped. I'm not saying this is the silver bullet, because whenever you move the chips, different incentives are created, and you never know. But at the end of the day, funding is clearly broken. It just is. It's not incentivizing the behavior that we want to incentivize, frankly. Interestingly enough, as I said, people really did take their hats off and say some pretty interesting things. We had some really disruptive ideas that came up, and if any of you are sitting there thinking you have the magic bullet in your head, I'd love to hear it, even if it sounds crazy, because it actually has spurred a lot of interesting discussion and follow through. I gave just some of the examples here. The one that you all might appreciate is the bottom bullet. We were sitting in Chicago, and there was one of the participants was a family care practitioner and primary care provider, and he said, you know, why are we doing this? Why are we fighting so hard and spending all of our research to fight against scope creep? Why are we doing this? Why don't we just go into the specialties people are forcing us to do anyway? We were talking about the Missouri law, where you can be an assistant physician and scope creep and all of that. And one of the women who was sitting there, who's a lobbyist, a government affairs person, she said, I've been up on Capitol Hill talking about primary care physicians forever. I'm making all the wrong arguments. Why am I doing this? It was really interesting to hear. Now, I'm not saying we're all going to go do that. Don't panic and run from the room. But they really did take their hats off and say, what should we really be doing here? What's really the better thing for the patient? Is it really fair that we stake out our ground and, you know, put our arms around it? Is that really what we should do? Or should we be a little bit more softer on the edges at least? So what we're going to do next is continue as a neutral convener. As I said, we do not take a position on GME per se. We have plans to convene a couple more roundtables. We'd like to hear from the residents themselves. I think that would be really interesting. Interested in your suggestions for how we do that. Do we pick the more senior residents? Do we pick someone who just graduated and went through the whole program? Do we pick young, the newbies? I'd love for your feedback on that. We're also going to be convening a roundtable with some of the private sector interests that we heard about. I want to know what's happening around the academic health centers that you guys need to know about, because then we can bring that information back to you to inform what you're doing. If you have other suggestions for any other areas of inquiry, let me know. We're really here to pull information and provide it to those that will be using it. On that line, I went in to meet with the different congressional staffers following our conclusion of our series, had some really interesting conversations. Clearly, all the bills that have been put forth to date say the same thing. We need more slots, we need to move money around, we need to get more money, more money, more money. And they're sick of hearing it. They don't listen anymore to any of the lobbyists that come in, frankly. They really don't. So they were shocked that I was in there to tell them totally other things, and they were thrilled. So I'm going to be going in and talking to them about other areas of their interest that might be interested in, deep dives into rural. They seem to care a lot about what's happening in rural healthcare practitioners. Interprofessional training is a big issue that they highlighted. So any other areas that you think you can provide further information, we'll take it. Any other stakeholders you think we should include, let me know. I would be happy to hear it. What I have said to them is, you bang your head against the wall doing the same thing, expecting the same result, it's probably not going to do you very much good. So I would suggest to them, and I have suggested, that they don't focus on funding. The minute you talk about funding, same arguments, same lobbies come up, nothing's going to happen. I said, why don't you do a hearing to focus on what is actually happening? Because as a non-medical person walking in and saying, wow, you're paying for all these residents? You're funding graduate education for these people who are then going to go make $500,000 a year doing whatever they're doing? No one funded my law school education. Wait a minute. What about those teachers that are not going to make any money? I mean, I'm an outsider coming in, and these are the questions that came through my head, right? If there was a hearing and the public realized that this is happening, and it was set up to provide for geriatric care in the first place, and that's really not even part of any of this, I mean, it's gotten so far off track. You guys are all used to it. You live it every day, so you don't maybe question it as much. But those of us coming in are like, what? What? I don't understand it. So what I said to them is, if you want to make headway on this, go after some of the problems. Put a hearing together talking about rural healthcare provision and how the GME program is not giving you what you need. Talk about how the private sector is running circles around us all. And what can we do to push our training so that we can train those future physicians that the population is going to need? Don't worry about funding. You'll get to funding in the back end. But bring out some of these issues so the public can be aware and support what you all are trying to do. So we don't take a position. I give them my suggestions. I will give them information. I will put groups together that will help them get more information. I'll try and move that ball along that way. But we will not take a position per se. So that's what we're going to be doing going forward. Any questions I can answer, I'd be happy to answer them. And I'll be around probably till about 3 o'clock today if any of you want to talk individually. Before I open for questions, any of you who attended the roundtables, is there anything you'd like to say about it or provide any flavor? Anyone? Not to put you all on the spot. Okay. Did you enjoy it? Did you find it useful? We did ask at the end, and you guys will attest to this. We did run around the table to every single person who participated and said, did you get out of this what you thought? What did you think it was useful? And everybody thought it was really useful, and they were really happy to have participated. So that was helpful. All right, any questions I can answer?
Hi.
Hi.
Thank you. This was great. My name's Tom Moore. I'm the Associate Dean for GME at a new university we're starting in San Antonio, but was formerly from here in Denver.
Great.
While it doesn't specifically go with academic health centers, it seems like for once the government came up with a model that worked in the teaching health center program, the teaching health center model, and now it's gone. And so now we're at a point where we can say, look, we have 5 to 7 years of data that shows that this works, and yet we no longer have funding. So to go back to what you're saying, we can't go in and talk to them about funding. If we don't talk about funding, it just goes away.
Not necessarily. Talk to them about why it's a good idea. Show them the results. Bring in people to testify as to how this really works. Because then you take the wind out of the sails of the hospital associations. And I know there's a AAMC person here, so I'm not trying to attack, but take the wind out of those lobbyists that say the same thing every time. Give them examples of how it actually works. And I know, like Dick Reisenbach, he's been in there talking. There's other people talking about just that. But if you go in asking for money or change the funding, they're just going to tune you out. They really are.
Thank you.
Yeah, you're welcome. Anyone else? I couldn't have answered all your questions.
I spent most of my life in these things called academic health centers, and it's kind of amusing. If I look across the room, I think everybody in here, even though we got a lot of old folks like me in the room, we really never lived in a world without them. But they're actually sort of aberrant, unusual, recent historical creations. The world managed to get along without academic health centers for a very, very long time. And so what impresses me most about academic health centers right now is how well they're positioned for interprofessional education and how badly it's going. They're not designed to do that. In fact, so I'll pick on my hometown again. We have the nation's only brand new academic health center, purpose-built from the ground up on 232 acres. It's gorgeous. It's one of the most wonderful places to work you can imagine. We have east side, west side, and north side meetings to try to get the people that have gone to all this trouble to aggregate out there. Children's Hospital came, the VA is trying to come, We're all out there. We have to call conventions to get the nursing school and the pharmacy school and the medical school, and we simply will not agree to a common calendar. Why do we keep these things?
Great question. Great question.
So just let me ask you. Just imagine you got such a rich biopsy of the state of these academic health centers and what they're trying to get done. Do you really think they'll still be here in 20 years?
Let's be provocative, shall we? If you do things right, you will be. Yeah, if you don't ignore what's happening around you, you will be. If you start working together instead of against each other, you will be. I don't understand why you all fight each other. I would bet if I went up to a hospital today and said, are you getting the resident you really want? Are you getting the product that you're hoping to use here? Is it really the best product you can imagine you're getting? They'll say all day they don't want to lose the money, but I'll bet that you could get some people to say, not really. We'd like it to be slightly different. But they're afraid to say anything because God forbid they lose the money or the control. That's why these roundtables were so refreshing. People took off those hats and said, how do we actually fix this? If we can have more of that, more of an open dialogue and more of an initiative to change it, I think you can, right? I think the AAHC is uniquely positioned because we work with the CEOs of all your organizations, the senior management of all your folks. They have, in many cases, not all, the power to make some of these changes. So that's what we're trying to focus on. But you can't ignore what's happening around you. You can't put your head in the sand. You can't think Congress is going to fund you forever. They're not. They're not. It's not going to happen. So how do you solve some of these problems? You're already doing it. You're going around the system and doing a great job, adding more slots on your own. The rural examples I've heard are phenomenal at your own cost. I mean, some of these things are really awesome. People aren't hearing about those things. They're hearing about you complaining about keeping the money. Oh, you're not going to win any arguments that way. So I think you can, and I think academic health centers are in the perfect position to push a lot of these things, more than anyone else. So I hope that you do. That's my interest. Yes?
Hi, Lou Sander from Wisconsin. Sympathy?
Go Big Ten.
Exactly. Yeah, University of Michigan, whatever. Anyway.
Oh, okay, you can sit down. Next.
I would challenge that academic health centers as currently defined, and I don't know the membership of your organization, but I assume I know the membership of your organization, are in the best position or the only position to do interprofessional education. We have a residency in northern Wisconsin the clinic is sited in the community college, and in that clinic and its environments, they train 30 different kinds of health professionals, including RNs, phlebotomists, radiographers, it goes on and on.
That's awesome.
And you probably wouldn't define them as an academic health center. And the AHEC systems in many states provide a lot of interprofessional education in communities who think of themselves as rural. I like the definition of rural as 200 miles from like an academic health center. I don't think the population sees it that way.
Within 200.
It's sort of like if you're 200 miles from a Burger King, you're in a food desert. I mean, like. But just to challenge that issue that academic health centers are, in fact, as currently defined, in that unique position for interprofessional education. I was a Stanford medical student, during which time they closed the nursing school because it wasn't academic enough. And they were in the process of closing the physical therapy school because it wasn't academic enough. So I don't know that academic health center's value set actually promotes interprofessional education.
That's a great question. We heard a lot of different models, and certainly the community health center approach was cited many times. We actually heard a really interesting description of the Uniformed Services University, the way the DoD does it, and they're cited as one of the best in terms of interprofessional training. Just team-based approach to the military, it's just their DNA, right? They do a really good job. So I think there are examples we can look to. But I agree with you, there are stovepipes that I don't understand. I don't get it either. I don't know why we're not all working together. I mean, I know that there's some states where the nurses have the same program across the entire state, so they've been able to make strides just within their own worlds. Why are we not joining with them to do a better job? I don't know. And I don't know enough about how stringent the academic standards are, whether they'd be a barrier or to what degree they'd be a barrier. I just don't know enough about it. And I'm not going to say anything more because you're from Wisconsin. Yeah. Yeah, one more question.
I'm Kevin Verderame. I'm from Iowa. I'm also the president of the American College of Osteopathic Family Physicians. Appreciate that you're representing the academic health centers, but I think important to recognize that there is a lot of GME that goes on outside of academic health centers, whether it's teaching health centers or it's small community hospitals that are working primarily in primary care training in that. Is there any plan in the future to draw in and expand your listening and roundtables to those who are outside the academic health center but are involved in GME production?
We did in this process, and we may not have expanded it as much as we could, perhaps, but we did include, for example, NIH, we include DOD, we included University of Maryland, which is a whole other system. Kaiser was there with their GME person. So we did expand it to a large degree, as much as we could in this effort, but I'd be very happy to have some additional sessions. And if any of you want to recommend to me different individuals or different areas of the country that would be good for that, let me know, because I need to rely on you to help me with that. I'd also be interested to hear any best practices in any of these areas, because Congress is asking me, what are you all doing? Because you're doing amazing things. I've heard all around the country what you're all doing. I want to be able to share that with them. So if you think of any examples of interprofessional training, rural, any of the areas I covered, I would be thrilled to share those with the congressional folks. So, well, I will be around till about 3. Happy to answer any more questions and chat with you offline.